So for localized kidney cancer, the main options are surgical, ablative, or active surveillance. So surgical could be either radical nephrectomy for the more aggressive cancers, but we really try to prioritize preserving as much renal function as possible. So partial nephrectomy. Another option for smaller renal tumors is thermal ablation, cryoablation, or radiofrequency ablation. And for small tumors or predominantly cystic tumors or older frail patients, we'll lean more towards active surveillance. So at one point, we mostly were managing patients with radical nephrectomy 30 years ago, and one of the major trends has been towards trying to save the kidney whenever possible, and we can accomplish that in the great majority of patients. So that's partial nephrectomy, thermal ablation, active surveillance, and just in general, the less aggressive of those options have become more commonly utilized through the years. So we're putting more and more patients onto active surveillance as we've learned more about the tumor biology. And also for small renal masses, we've come to recognize that thermal ablation is also a very reasonable option for many patients, especially if they're a little bit older or they have more comorbidities. So just in general, thermal ablation has the best sort of morbidity profile. The complication rate is relatively low. Patients go home. It's basically an outpatient procedure. It's percutaneous, image guided. They go home the same day. So the lowest risk of morbidity and complications will be thermal ablation. In this era, we're doing the great majority of the surgery now minimally invasive. Those patients go home usually the next day. So partial nephrectomy in general tends to have slightly higher perioperative morbidity than all of the other options, because with partial nephrectomy, we're leaving behind a highly vascular organ, the kidney, that's been reconstructed and it needs to heal. So there's always going to be a small risk, even with minimally invasive surgery, a small risk of postoperative bleeding, 1% or less risk, small risk of urine leakage. And then the final option, radical nephrectomy, in general tends to have a lower risk of perioperative morbidity than partial nephrectomy because it's cleaner. We take the whole kidney out. And even with radical, we can do probably 80% of them with a minimally invasive approach and with the patient going home the next day. There are still some patients with really large locally advanced tumors who really need open surgery. Well, so who qualifies for thermal ablation? It really doesn't work well if the tumor is sort of moderate size or large. So in our mind, we're mostly targeting small tumors, 2 centimeters, less than 3 centimeters. Sometimes you can push the envelope and treat slightly larger tumors, 4 or 5 centimeters. But to get a strong efficacy, just in general, patient selection is key. And the best candidates for thermal ablation are going to be patients with really small tumors, 2 or 3 centimeters or less. Downside, I mean, these patients tend to recover very well, but one of the really important factors is tumor location. So if there's bowel or pancreas right next to that tumor, that's going to increase the risk of complications, although often we can infiltrate saline and expand the tissue plane and allow for a safe thermal ablation even in those settings. The other thing that's really important with tumor location is if the tumor is right next to the vessels, the hilum, or the collecting system, if we're going to ablate that, we're going to run the risk of losing some small risk of bleeding and losing blood flow. So some tumors, even if they're small, still need surgery because we really can't treat them safely or effectively with thermal ablation. So really what's on the horizon is probably sort of like extracorporeal approaches like SBRT or other sort of energies that we can deliver without even having to put a needle in. And actually today at the meeting, there was a very nice presentation showing how the radiation, the sort of accuracy of the delivery of the radiation has continued to improve through the years, and the data in favor of like focal therapies with like focal radiation like SBRT is starting to become fairly strong. And so I think the vision in the future will be that we won't even need to stick a needle in to treat a really small renal mass. Now, of course, most of these small renal masses have low biological aggressive. They're either indolent or benign, and many of those tumors may not need to be treated at all. So in this era, we're observing a lot of those.